بسم الله الرحمن الرحيم. السلام عليكم أعزائي الطلبة. This is a third lecture about the vestibular disorders. I will talk about the vestibular system and benign paroxysmal positional vertigo. Vestibular system consists of two parts: the peripheral vestibular system and the central vestibular system. The peripheral vestibular system consists of the maculae or otolith membranes of the utricle and the saccule, which are responsible for the acceleration and deceleration of the linear movement and the gravitational movement, and the crista ampullaris, which is found within the ampullated end of the semicircular ducts, which is responsible for the angular movement of the head. The central nervous system consists of the vestibular nuclei within the brainstem and their central connections within the brainstem and cerebellum. What are the functions of vestibular system? Vestibular system responsible for maintenance of balance and posture and prevent fall through a vestibulospinal reflex, and keeps eye focused while body is in motion through a vestibulo-ocular reflex. What are the causes of vertigo? We have peripheral causes and central causes. The most common peripheral causes of vertigo: number 1, benign paroxysmal positional vertigo; number 2, vestibular neuritis; number 3, Menier's disease; number 4, vestibulotoxic drugs like gentamicin and anticonvulsants; and number 5, trauma. While the most common causes of central vertigo are: number 1, migraine; number 2, brainstem ischemia or infarction; number 3, multiple sclerosis. Benign paroxysmal positional vertigo or capulolithiasis or canal lithiasis is the most common cause of peripheral vertigo. It constitutes about 20% of patients in vertigo clinics. What is the pathology and pathogenesis of benign paroxysmal positional vertigo? We have the maculae or otolith membranes. These are the otoconia or calcium carbonate crystals at the top of the otolith membrane. These crystals or otoconia sometimes sheared off and dislodged from this membrane and falls into the semicircular canals. Most commonly, they fall into the posterior semicircular canal. Question: can these crystals fall into the superior or anterior semicircular canal and the lateral semicircular canal? Yes, can, but very rare. So, if these crystals falls into the posterior semicircular canal, so it is called canal lithiasis, and they are accumulates over the copulae of the crista ampullaris, so it's called copulolithiasis. If they are accumulate over the copulae of the crista ampullaris, cause movement of these copulae, and any movement of the copulae can provoke vertigo. But what are the causes of benign paroxysmal positional vertigo? What are the cause of dislodgement or displacement of these crystals? Number one, old age, as a degenerative process within the maculae of the utricle. This degenerative process causes shearing of the crystals and falls into the posterior semicircular canal. Number two, head injury. Number three, if the head in the same position for a long time, such as in the dentist chair or at the beauty shop or on strict bed rest, can cause benign paroxysmal positional vertigo. What is the clinical features or the clinical presentation of benign paroxysmal positional vertigo? Usually, the patient with benign paroxysmal positional vertigo present with a sudden onset of severe rotatory vertigo, and the duration about few seconds. And the attacks provoked by a sudden change in the position of the head, either during the patient getting into or out of the bed, or during rolling over into the bed, or during elevation of the head. These procedures can cause and provoke a benign paroxysmal positional vertigo. And vertigo usually lasts for seconds, and vertigo disappears when the patient stops moving. There is no associated features of cochlear involvement. There is no hearing loss nor tinnitus, and no any neurological features, just vertigo for few seconds provoked by a change in the head position. How can we confirm the diagnosis of benign paroxysmal positional vertigo? By a special test called Dix-Hallpike positional test. What is the procedure of Dix-Hallpike maneuver? We should examine both sides. We start with the examination of the right side. We ask the patient to turn the head 45 degrees towards the right side, and then we ask the patient to lie down with the extension of the neck about 30 degrees, and then we examine the patient for the positive signs, which are number one, the presence of vertigo, and number two, a nystagmus with characteristic finding. After that, we examine the patient with the turning of the head towards the left side, and we repeat the procedure on the left side. What are the characteristics of nystagmus, which is specific for benign paroxysmal positional vertigo? Number one, it is a rotatory towards the underlying affected ear. The nystagmus is directed toward the examined and undermost ear, and it is rotatory. Number two, it has a latent period of about 1 to 5 seconds, up to 20 seconds before starting. There is a latency of about 20 seconds. Number 3, the nystagmus lasts between 10 to 30 seconds, up to 1 minute. Not more than 1 minute. And number 4, fatigability of the nystagmus. What we mean by the fatigability, we mean slowly settle down of nystagmus and shows adaptation, which means the nystagmus lessen within consecutive test. يعني كل ما أعيد الفحص مرة مرتين ثلاثة أشوف ال duration of nystagmus يبدأ يقل إلى أن يختفي. This is called fatigability of nystagmus. So the characteristic finding of nystagmus of benign paroxysmal positional vertigo are: number 1, latency of about 2 to 20 seconds. يعني النستاغموس يتأخر إلى حد 20 ثانية أو أقل إلى أن يبدي مو رأسا. Second, duration of nystagmus lasts up to 1 minute, less than 1 minute. Number 3, fatigability. Number 4, presence of vertigo. This examination, Dix-Hallpike test, provokes severe vertigo during examination. And the direction of the nystagmus is rotatory and directed towards the examined and the undermost ear. What is the treatment of benign paroxysmal positional vertigo? The treatment is based upon bedside physical therapy maneuver, which is called Epley's maneuver. And the Epley's maneuver can bring 90% relief from benign paroxysmal positional vertigo. What is the procedure of Epley's maneuver? We assume that this patient has vertigo towards the right ear, and we diagnose the direction of positional vertigo according to the history and according to the Dix-Hallpike test, and we find that the vertigo and the affected side is the right side. So we repeat the procedure of Dix-Hallpike test. Number 1 and 2 are similar. We start with the turning of the head of the patient towards the right side, 45 degrees. Then we ask the patient to lie down with the extension of the head 30 degrees. And we should hold the position for 30 seconds or until vertigo disappears. Then, this is step 2. Step 3, we rotate the head 90 degrees towards the opposite side, towards the left side. And we ask the patient to hold position for 30 seconds or until vertigo disappears. Step 4, we ask the patient to roll onto left side and rotate head towards left side until nose is angled towards the floor, like this position. Also hold the position for 30 seconds or until the vertigo disappears. And step number 5, we help the patient into sitting position and facing left. Also hold the position for 30 seconds. And then we ask the patient to sit in a neutral position with his face forward. This maneuver, Abley's maneuver, can cure up to 90% of the cases. And we can repeat this maneuver if the patient in need for the repetition of the procedure. Thank you very much and good luck.